Next is a panel discussion, and I'll invite the moderator, Professor Geeta Krishnan from Civil Engineering, who is a specialist in traffic management. Today, his job is to manage the panel. So without much, because we are slightly running late, I'll just ask Geeta to come and introduce the panelists, and then we can start the panel discussion.
So, very good afternoon. I think we've had a lot of technical presentations, and then you also had the small break that Bobby gave us, right? So now we'll move on to panel discussion, right? So I think Himanshu was mentioning that I'm a traffic specialist. I have to manage the traffic of questions, right? But I also wear a different hat. I think that's why Ravi put me on this panel today. Right now I'm on a sabbatical and I'm working with a startup, right? So I think Ravi thought maybe I'm struggling, and so therefore I can bring out some of the questions, right, with passion. And not directed at the panel, right? So that's what I think Ravi meant by having me here. So what I'll do is I'll quickly call out the panelists, and then they can come up. While they walk up, I'll just briefly introduce them. So we have Raghu Dharmaraju. So he's a CEO of Art Park at IISc, and he's built scaled innovations institutions for social impact for over 2 decades, right? So Raghu, if you could, yeah. Then we have Sudarshan. Of course, he's our alum as well, and so we are very glad to have him back. And then we have Sudarshan, who is an AI guru, and he's spent 19 years on NLP technologies and over 15 years on machine learning, deep learning systems, right? And I think his company works on healthcare, right? So I think that also makes him eminently qualified. Then, of course, we have Sam Mehta. So he's the vice chairperson of Dr. Mehta's Hospitals, right? And he's the director of Atlas Family Office. So he's very passionate about innovation, investing, right? He's co-founded Indian Home Healthcare and participated in many committees. So he's, of course, a constant in a lot of our events, and we value his input. So glad you're here. And finally, we have Padma Chandrasekharan. So she's worked for over 30 years as an executive and board levels, as an entrepreneur in world-class organizations, including a senior program manager for the Bill and Melinda Gates Foundation, which is supporting a lot of healthcare innovation in our nation right now. So welcome Padma. And she's also an angel investor and member in the Chennai Angels, right? So I think she'll have some perspective on, so when Ravi introduced this panel to me and said, you have to moderate, I sent an email to all of them requesting them for some thoughts, right? And what I didn't expect was a deluge of thoughts, right? So a lot of questions came up. So I have a lot of things up here. But what I'll do is I've kind of grouped them into a few topics. And but before I start, I thought, no, I'll give a minute to each of you to quickly, share your initial thoughts about being this panel, right, about healthcare, startups, and AI, what role it has to play. So maybe I'll start with Raghu, if you could.
Sure. Good morning, everyone. We are between you and lunch, so let's try to keep it brief, I guess. I think we've been talking about the potential for AI, ML-based solutions to have an impact for a while now. So, yes, we've had some initial success, but I think we can all agree that the gap between the promise and what we have delivered so far is very big. And hence, the sort of questions I grapple with is, what is it that we need to do that we help many startups at once, as opposed to betting on single startups? With that, and I think there are some systemic issues there that we have to address, both in how we do innovation as well as how we adopt and validate innovations into practice.
Good afternoon. So, putting aside all the challenges and the problems that one may face in running a AI company for healthcare, I am motivated about the opportunity which is out there, right? So every problem one goes through can be seen as a deterrent can also be seen as an opportunity. I look at the opportunity side of it, and as we all speak, AI is still in the nascent stage with respect to deployments in the healthcare vertical. So it has amazing potential for enthusiasts to work in that space, entrepreneurs to start companies in that space, and interesting times ahead. That's what I'm looking at. Thanks.
Yeah, I'd actually agree with that. I think this is one of the most complex industries there is. Just like the human body is a highly complex, highly interconnected system, I think healthcare startups, for their success, where they work with hospitals, with clinicians, the enablers, or gatekeepers sometimes, and then customers downstream. I think the opportunity is huge, but the complexity is also significant. So I think that's something that you have to keep in mind as a startup, that it's a slow burn, but when it succeeds, it tends to be big wins. So huge opportunity. I think one of the things you'll have to overcome, and we've got some clinicians in the audience, it'll also be good to see some nurses in the audience and perhaps allied health. Most of them have been scared a little bit because they think AI is taking over their jobs. And I think that is a misnomer. It's like the old days, somebody used to say that the mobile phone will substitute a lot of roles. But what happened is people who learned how to use, whether coding in the early days or mobile phones better, they were more successful than people who didn't learn it. Right? So I think the opportunity, if you're able to pass it well, is huge. And I think the solution space in India is specifically unique because such a huge market, the playbook of the world does not work here. And in fact, the playbook of the world doesn't work in those parts of the world either. You look at healthcare quality, lots of different things. Governments are struggling to face the healthcare burden of pricing as well. So we desperately need solutions that are automated and hopefully lower in cost.
Thanks. I would prefer to unpack or disaggregate this question a little bit. On the one hand, you have startups. That's a different, there's a whole set of issues associated with startups, challenges and the way they operate, getting customer acceptance, getting community acceptance and so forth. The other half to my mind is this whole question of AI and health. So let me take the first half. I think we all know the issues. I'm not going to waste much time talking about startups because we've all been now seeing startups for the last 15 years in this country. If you look at the AI and health, I think the first thing I'd like to do is to just, split it up into old school machine learning, of which there's actually quite a bit, being deployed in imaging, for example, where it's fairly easy, categorical data or categorical analysis is being done. Then you have the whole generative foundational model kind of work to be done on AI. And I think here some of the issues will be, you're trying to, are you looking at diagnostics? Diagnostics is to me, one part of the chain. Or are you looking at prescription thereafter, as in, you have a diagnosis and then you prescribe that this is not medicine, I'm talking about prescribing the way forward. And I think in both these, in the diagnostic area, I can certainly see a lot, of work happening to use foundational models. In the prescriptive area, I think I'm a little more, wary of that, essentially because, finally a doctor takes a Hippocratic oath. I don't know that you can subject an AI model to a Hippocratic oath. So, that to me is the conundrum. I mean, there's a lot of other issues that I don't want to waste the first 1 minute on. I'm sure we can discuss more as we come up.
Yeah, so I think already there is a spectrum of topics that we can take on, and I think each one of these could actually be the full panel itself, right? But one thing that kept coming up was data, right? So maybe I'll start with that, right? Because all AI/ML starts with data, right? So any specific thoughts on data itself? And of course, there are regulations. Indian regulation is also already tabled. It's going to come soon. What do startups have to do, right, when it comes to data? Right? What are the challenges? What are the opportunities? So, Sushin, you would like to start?
Okay. Yeah, absolutely. So without data, there is no AI, that's for sure, and there is no company either. So most of the companies, when they have an idea and they start working on nurturing their idea, they are stuck with the availability of the data. But today it's not that bad because there's a lot of public domain data available with labels most of the times. So it is not like 10 years back. So when we founded the company in 2013, there were not much data available in the open space. Today, healthcare has opened up their doors to welcoming research, academic research, industrial research folks to come in. So the situation is not very, very bad. But you get to consume the available data very quickly, right? You end up using it all up and then say, no, I need more, I need more. And the other problem one will go through is, okay, you have played with public domain data. How will your technology extend to real data from real scenarios? Can it generalize to that? So that's a challenge. We will not have an answer when a potential customer or a potential investor asks a startup with that question. I don't know how to answer that because I've not validated it, right? So you may have to dodge that question somehow, and then maybe persuade them to give you an opportunity to test it in a real scenario. So that's how it goes usually. So when we founded the company in 2013, the first dose of real data came into us in 2015. So the first 2 years, we were dabbling with whatever was available out there in the open, which was fairly slim. And then we also managed to make friends, let me be honest. So we sneaked some data, right? Without breaking the law, of course. Of course, India does not have any stringent law about PHIs and all. But in the US, it's very, very hard to sneak data out of a hospital or out of a clinical practice. In India, sensitivity towards protected health information is not that much. I mean, if you go to a hospital and ask a fellow patient sitting next to you to share their medical report, they'll gladly share it with you. In the US, it's a crime. You can be put behind the bars to peek into someone else's medical chart. So the situation is very different. And we were focusing on US healthcare back then. So we managed to get snapshots of information through channels, through prospective channel partners, prospective customers. So it was hard. It was supreme hard. But now I can proudly say that I have access to several millions of healthcare charts with me. I mean, acquired over a period of 10 years' time from our customers, from evaluation measures, from validation experiments, from competitions, and different avenues are there. So as a startup, you should have an open mind, be shameless, asking for data. I mean, I have begged for data. I have no problem with that. Because without data, I don't have a life, right? So be absolutely shameless in seeking data. And it works sometimes, right? Fellows, Sam is here. I mean, if I go to him and ask, sir, please give me data, he might consider. But if I say, will you share the data with me? He will not consider, isn't it? So data acquisition is a challenge, but it is not impossible. So I'll park my argument there.
Sam, I think you talked about, yeah, exactly. And one of the concerns you often raised, how do I, trust startups with data? So would you like to throw some light on that then?
So I think look at it from the different side of the coin, right? If you're a hospital or a doctor, actually whose data is it? It's the customer or the downstream patient, and it's highly sensitive data where if it's in the wrong hands, it could technically be abused, right? So I think the risk to the institutions is very high. If your data gets stolen, hospitals fall over overnight. These are institutes that are built over lifetimes, decades, and hard work, and it wouldn't be, 3 seconds of data theft. And many of the institutes that have already suffered this are seeing the realities of now no longer being in the hallowed lights. So I think whether you're a doctor and you have your patient's data stolen, your patient won't come back to you again. You will no longer be the bastion of trust. Same with hospitals. So in some ways, you're a gatekeeper. I think we have shared data. We do that we first try and figure out whether these guys are trustworthy, right? There are some that come to us in the early days and look very trustworthy. The problem is, what do they look like 5 years down the line, 10 years down the line with that data? Are they using it well? Are they there to help? Or there are people who've also stolen data. Let's be honest, under fair MOUs in the past, in most hospitals in India, that's common. Actually, in most in the US, it's also common. The only difference is the US, we're about 20 years behind it in some ways for data the sharing laws and the information exchanges. But I think we're accelerating faster than anything else in the world. Maybe China is an exception, but that's centralized. Basically, government takes a regulatory perspective. But I think the rest of the world, for us, we are trying a playbook that isn't there. So I think if you're a startup and you want access to data, come and make friends. I think he's absolutely right. Right? I think the second is, I'm hoping organizations like Serai and with some of the DST, DBT folks, put these kind of like black boxes which say that if data is taken out of this group that is trying to develop, clean up data, label data appropriately, and it's stolen and perhaps misused, the institutes that have helped make that possible are to an extent protected, right? So you have to anonymize, you have to clean up, and I think, so therefore there are 3 steps perhaps before we start talking about data exchange and availability to the open market. Can we get somebody to help with cleanup, with labeling and anonymizing? And if you can do that with hospital groups and doctor groups in this ecosystem, I think that will enable the ability for a startup to access huge amounts of data much faster. So I think the opportunity is very different in India. We haven't seen startups that help you in the first 3. We see a lot of startups trying to say, I can do the next X-ray. In fact, we have 3 IIT startups on CT and X-ray for thing, including our friend here, that say we'll give you a superior algorithm, better than your doctor, to do something. I mean, he's at least kind. He says he won't substitute the doctor, he'll assist the doctor. That's what he says. But I think if we can figure out the data exchange or moats and some way of cleaning it up, that will help all hospitals. It will definitely help doctors. Doctors want to publish their data, right, from their patients. And I think it can help with that. It will actually go a long way to making better friends.
Sure. Padma, you were mentioning about multiple sources, multiple outcomes, and data being, so would you like to?
Yeah. So, I mean, I've worked with a number of startups who are doing this kind of, this was, pre-generative AI, by the way. The old ML, simple logistic regression, that kind of work. And typically they would be mostly working in imaging. That's in fact the only field that I've seen where people have had a little bit of success and, at least have contract with hospitals. So your first challenge is to work with is to get the first hospital on board, and there has to be something in it for the hospital. I'm now, for hospital or the clinic, or the healthcare center or whatever it is. I'm now just setting aside the issues on, concerns about data loss. Typically, a hospital's concern about the data loss is because of 2 things. One is they fear that if it's not anonymized, if it's not de-identified, then you basically lose patient ID, and that can, be used as a source to harvest new clients or new patients by some other healthcare facility. That's the number one, and Sam will, confirm to me if that's right or not, but that's what I've seen in other healthcare locations. The second concern is, is actually secondary. It's much more minor. It's this whole thing of reputation. I have, let a lot of patient data out. Frankly, the fact is, once you've de-identified or anonymized the data, it doesn't matter too much. Now, I just wanted to clarify that part. The bigger challenge, I think, is to aggregate multiple data sets. If you get it from a particular hospital, there will definitely be all kinds of recruitment biases. Leave alone that, you need to be across 500 hospitals in order to be able to, really validate something. Then you're talking about, now we're no longer talking, let's say, about imaging. Let's say you're talking about something that's more foundational. I don't know if anybody read the recent JAMA, Journal of American Medical Association. It's, the premier medical journal in the world. They were talking about foundational AI. The challenge is to be able to aggregate multiple kinds of data. So not just imaging, but let's say, biomarker data, patient reported symptoms, doctor's observation. There's so many things that you want to be able to aggregate in order to build a model. So, that itself is going to be challenging. Now, in most US, hospitals now, they use a system called EPIC, which has been around for the last 40 years, but it's become very good. So you go into a wild cornell, for example, I just type in a few keywords and I can get my entire medical history, pull up all my charts and so on. That's not a facility that's available from any hospital in India, because there is no, hospitals in India are still, they're in the money-making stage, and I don't think that there's any law that forces them to, make patient data available. Because you don't have to, make it available, it's much, therefore there's no incentive to aggregate, to, consolidate all of this data. So I don't know if I'm making sense, but these are some of the issues that a startup will face. Most of all, I think, first of all, a startup has to decide what is the problem they're trying to solve, and why on earth do they think they're going to be better than the medical practitioners currently working on the job.
Can I add a couple of things?
Yeah, and also, you were mentioning about the long lead times for data, right? If you could throw some light on that.
Yeah, so I think the first question to ask is actually, I'll pick up on what Padma said, Sam said, right? One is, what is the data for? Right? Typically everything we do with data falls under, a spectrum of exploring, looking for new patterns versus exploiting a pattern that you know and now you want to build some solution based on that, right? So what's the data for? Now, if you are a startup and say, I want to go, give me all your data and I want to do some exploratory stuff, that's often a difficult place to start, right? I don't know if you're going to be able to just hand over data like that, right? So to do that sort of analysis or exploratory research, I think the research institutes, academic institutes are a good way to work through to make that happen. Now at the other end, you say, I have something, I have some claims on this algorithm, I want to now validate it, right? Who is to validate? Sure, every hospital will want to validate. At some point of time, you're going to be frustrated that every hospital wants to do their own validation, etc. Right? Towards this, we are actually working with ICMR in building a system that brings together data in a distributed manner and an ongoing manner, in a way that helps, especially to start with, in diagnostics and screening spaces. Happy to share more about it, but this is, you said there's lots of data available. You have a lot of that data because there's an NHI or NHS type systems that exist elsewhere that are making data sets available to you to get started. That's often your starting point. Wouldn't it be nice if India had a starting point similar to that for lots of startups? And this is where one of the things that I find myself often a bit of a soapbox is, lot of research and philanthropic funding has taken an approach of a VC of trying to back one or two winners. I think we need a race course redesign here, right? And that's where I think there is now progressive thinking happening with the ABDM, Ayushman Bharat digital mission coming in, laying out foundational DPI, DPGs for health data to come together. But we know a mature EMR system by itself is not going to lead to complete enough, accurate enough data for a given purpose. And for that, we are working on complementary systems. So yes, this problem has gotten attention, and I think there's a lot of role that both private sector hospitals, as well as especially, and often yours are the hospitals that are actually at the leading edge of thinking and doing. So there's an opportunity to actually collaborate and make stuff happen here.
Sure, yeah.
So I'll give you a simple cue. So to have access to the data from a hospital, to Sam's concern, the primary contention is around patient information. We call it PHI, right? Protected Health Information. So when we ran into such issues, the first tool that we built, or the first technology that we built, is a method for de-identifying data. That's what we built. And the algorithm that we have in production is at least 98% accurate now. I mean, it cannot be 100% accurate. It can never be possible. So it's at least 95 to 98% accurate. So when we pitch in with this available tool to a hospital, the hospital is more motivated to talk to us. Because I'm not saying, give me your raw data. I'm giving you an algorithm, run it in your environment, clean up your data, perform a small audit on it, and then share the cleaned up data to us. That way the risk is mitigated on both directions. So if you approach a hospital seeking data, maybe the best place to start, is to either develop a technology which will clean up data by yourself, or have access to an available open technology which you can tune to make it work better, and then go talk to a hospital saying, I have a way to clean up the data. So the risks on your side is lesser now. So that could be a good starting point, in my opinion. It has worked out very well for us.
Sure, sure. I think maybe if this repository you talked about, or if an academic institution can take a lead in that and develop that tool, right, make it available, get a lot of data, that could also be a possibility that we could consider, right? You'd like to share, yeah?
I think that's a nice top-down approach that has to be supplemented by a bottom-up approach, which, mandates that hospitals have to be providing the patients, regardless of their literacy level, with the data when they want it in a computerized form. Not, come and take this piece of paper and come and take this X-ray and come and take this CD-ROM, which is currently what happens. So if you if you mandate that, then, the hospitals, they willy-nilly will have to put all of this on mass storage, will have to, have a way to link different patient data to the same patient ID number. Anonymization, to my mind, is, that's a very easy thing to do. But if you don't mandate that from the top down, you're not going to get anywhere. I mean, this is a bunch of academic institutions. You've got to get the mass number of, hospitals to do. This is just my thought.
Yeah. So again, I think we should recognize progress is happening, right? I know we have challenges. So the ABHA number, the Ayushman Bharat Health, I don't know what the A stands for, ABHA number. So that's going to end up linking patient records. And you also have a consent mechanism that's also coming into place, through which the health information exchange, that includes me, the patient. I mean, it's very frustrating to go and have to take all these things home and scan them as PDFs, and ultimately that's not very intelligent information.
It's not
right?
useful to the community at
Exactly, right? So, but that's changing with the ABDM ABHA number coming. It's a slow transformation, but I'm sure leading hospitals can already play a role by being early adopters.
all. Since you're in a position to speak truth to the powers that be, my recommendation is that you ask for this, a simple law to be passed. We're passing laws left, right, and center. Every day there's something in the parliament. Just something that says the hospitals are mandated to provide online access to patient records. That will just kickstart an Epic Epic is a piece of software, by the way, deployment across all hospitals in this country.
Sure. So I think, data has been a challenge, but things are looking up, right? That's the message that we're getting. And like expected, this itself took quite a bit of our discussion time, right? But I think data, and then comes the models, right? The technology itself, including use cases. I'm sure there are plenty of youngsters here who are thinking about what's the next big idea that I need to work on, right? So maybe I'll quickly ask, the panel to suggest what they feel are the models or the technologies in AI, in healthcare, that you think will make it big or is essential, right, going forward. Anybody can start. Sam?
Anything that makes, I think, the nurse or the doctor's life much easier, I think, is low-hanging quick win fruit. Examples of that are data input methodologies for actually putting the patient records, so they spend time with the patient rather than the computer in outpatient. That's a low-hanging fruit. Something that self-auto-structures a patient record so that a doctor is not having to pass and fill in different sub-records, right, or sub-classifiers on what this is the prescription. It should automatically just pick this is prescription information, this is vital information, and just pass that automatically or classify that automatically. I think those are low-hanging fruits, and anything that will actually make the life of a clinician or a nurse better. Why is every clinician and nurse using WhatsApp? Because it made their bloody life easier. Before that, they probably didn't even use a mobile phone that often. Right now, everyone loves they share patient records quite openly. So I think if you make somebody's life easier, it'll get used. And I think that's the same that would apply downstream to customers. But for me, the lowest hanging fruit is really obvious: make somebody's life better.
I don't know if this will be the next wave, but I really hope so. Picking up on that, I was going to say language technologies is what I want. We don't think of them as medicine specific, but earlier we saw the presentation on LLMs, right? So I think that's going to have a huge impact in this space. And language input technologies will also have. And I've seen Sam say this, but I think there'll be certain settings in which it will especially make a difference.
So we have been working in this space for quite some time now. So the problem, the summary of these gentlemen's words is called as documentation, right? And there is a technical word called clinical document improvement. So it stands for CDI. It's a standard process in the revenue cycle management space of the healthcare processes. So documentation is a pain. It burns a lot of energy of the physician to document what has happened during the interaction with the patient, so on and so forth. And the amount of time a doctor spends with a patient is proportionately very small compared to the time spent on documentation. So if we cut down the labor on documentation time, probably the physician burnout is reduced, because the bigger problem that we talk about in the healthcare space is physicians burnout. I'm loosely using the word physician. I mean, all caregivers, I mean, any form of caregivers. It could be a nurse, it could be a pathologist, it could be a radiologist, it could be anybody. The burnout of these health contributors or healthcare contributors, if you reduce that, that's going to improve the overall system end to end. So when we did an investigation about this, or we wanted to understand what physicians really look up to. So Sam mentioned about the inputting system. So let's go one step further. So many of the doctors that we spoke to, they were very glad to use a technology which will read their voice and document it automatically. So we call it speech to EHR. Right now, it is happening like that only, but there is a lot of manual processes in the middle. So the physicians will give dictations, and the dictations are scribed by a scribe person, and then it gets verified by another technician. Then it comes to the physician for verification. The process is very complicated, laborious, right? It's worse, yeah. So, but what if we can get live documentation when the interaction is happening between the patient, the doctor, and probably an assistant? Could be a doctor's assistant or a patient's aide. This tripartite conversation, if someone can listen to it, some technology can listen to it, understand what is being spoken about, what is the diagnosis, what is the prognosis, whatever stuff that can be extracted out of that conversation, and can we get the first draft of EHR from that conversation in an automated fashion? It's fairly doable with LLMs available, with ASRs available already at our disposal, almost at free of cost. So technologies can be developed which can move from speech world to the documentation world, at least the first draft of documentation, and following the templates of the hospital, templates of the specialty, templates of the practice, it can be formatted in whatever way that is required. So we cut down the time, we cut down the labor, and we cut down the burnout of the physician. That's going to be a big winner. And this space is very nascent, not many players in this space. Microsoft has Nuance, and there is this M model. These are the only two players in this space right now. So people who work in ASR space, people who work in NLP space, you have a lot of opportunity to leverage and develop technologies and solutions to this particular problem. It's a big problem.
Now you're talking about generative AI use cases.
I mean, LLMs is
Sure.
lead to generative AI. So I really don't want to get back into that. I will just pick up where all the three of them have spoken. I completely endorse Sam. That, I mean, first of all, you don't boil the ocean. You're not going to be able to discover or, develop something that's so, momentous that the whole world turns around and says, wow. Find out what you can do to ease healthcare facilities. Here and now problem. Solve one problem for them, like he said. For example, if you can, just capture the speech to text, text to summary, summary to keywords, keywords to EHR. I mean, that's the path. You're already seeing Zoom, for example, providing minutes of the meeting. Microsoft Teams has been doing that for quite a while. WebEx has been doing it. Firefly.ai is an app that people now layer on top of Zoom sometimes. They prefer that. So everything's already there. So think of something like that, which helps them. Or on the other hand, think of what Sam said, that, as a doctor, I would really hate to spend my time filling up a form. Is there a way that I can just dictate and then that, goes into the form? So think of simple ways to get in and don't worry about solving, like a universe level problem.
Great. Start small and then grow big.
Make your way in.
Sure. So we have about 10 minutes left, right? So what I'm going to do is, I'll have a few questions, but I won't have everybody answer every question. It'll be like a rapid fire, quick question, quick answer from one of the panelists. And then, of course, I want to open it out to the audience, for them to weigh in with their thoughts and questions as well. So one of the things is regulatory hurdles, right? So how can a startup navigate this complex world of regulatory hurdles, right? Anybody?
I can take that. See, regulatory hurdles don't come to startups right away, but see, when you execute a very high value contract, right, that is when regulatory modules will come into play. See, when we wrote our first contract with a very large customer, we had to take insurance for everything. So there was one insurance clause which said, what if your software breaks? You have to get an insurance for that. It runs in multiple $1 million. I mean, what if the AI predictions were incorrect? There is one insurance for that. They were not direct products. I mean, in fact, insurance for AI is a new area. I mean, one of my friends is working in that space. So, I mean, how do you insure mistakes coming out of an AI system? So that's a new area. There are no insurance products for that today, but people are thinking about coming up with new products. So when you go into a high value contract, only then the large vendor, large customer is going to demand for compliances and authorities. I mean, see, in the US, you have to get a basic certification called SOC 2, SOC 2. Without that, you don't get any contract. And if the value of the contract is higher, then you have to get high trust, is another compliance certification. And you can also aim for ISO 27001, which is another certification you need. But these things will come into play when your contract value goes up and up and up.
So they can learn this as they go.
As they progress, yes.
Not need to worry about it right away.
Not today.
Great. So
I'll just say don't cut corners. Get your ethics committee.
sure, get your ethics committees in place. Don't cut corners, right? Next question I had was customers. As a startup, who should their customers be? Should they look at B2B, B2C, government, private? Any quick thoughts?
Anyone but government as your first customer. I've built a medical device company that predominantly was focused on public health. But government, think of your path being you will need to find early champions somewhere to get started with whom you actually have a deep understanding of the problem and how your solution fits in, right? And go from there.
If you already have lots of oxygen, meaning fuel, then I would accept the government. Otherwise, don't start there because you might get paid by the time you've gone around the planet a few times, right? 2,000 times, right? So I'm not trying to put down the government, let's be honest. I think, look, find concentrated groups of customers who will pay you on time and value what you have today. Think about that a few seconds. So if you can find concentrated, there are 80,000 hospitals in India, but actually only 1,000 have any sort of head of technology, CTO or CIO. Data scientists, less than 50. So go find the right champions. It's that old adage from IIT or any other school that you guys, university studied, go look at you will find the subject or you find the professor. Find the best professor and you'll learn much better than any subject-specific discussion. Guys like Ravi and Manikan and many people, I mean, we can, including you, not excluding, but
sure.
Find the right prof, right? But I think find the right champion. So I think if you can find the right champion, and there are probably only about 20 of these guys worth working with today. But that hope is that 20 becomes 100 so on. So I think if you find concentrated groups, it works. When you go and chase the odd doctor, the problem therein is you'll start your journey, but whether the scalability validation is really correct, I'm actually confounded. I think most of the time they actually take them down the wrong path. I'm not saying that clinicians, because most of them bloody sacrifice a lot of their life to do something useful, but when they're able to understand scalability, that's not normally the subunit they look at. Sure. Right? So I think look at that scalability, but if you have a lot of oxygen, you can
go after the
follow the sun.
Great. So,
Vitamin M. Yeah, that's what I mean, vitamin M.
Yes. The other question that I had was, regarding funding, right? Funding. So that's always, the burning question that startups have, right? And I can see Sam giving the mic to Padma.
So my answer to funding is first self. So I want to know what you have done to fund your company. So, have you, for example, taken a loan out in your name, in your, whatever it is. Next is your family. Then is your friends. Then after that, you will, go out to maybe a few angels who you can convince. Then only you can even start thinking of a network of angels, which is a more formalized institution. Then you can start thinking about seed from an established venture. So, but first, any investor is going to ask, why should, if you're just, let's say a fourth-year BTech student, it's very, very unlikely that that kind of startup is going to go to some really great lengths, unless there is, maybe there's some strong institutional backing, or you've got, father's money to fund you. So, self, family, friends, friendly angels, then angel net. I mean, there's a gradation to this. Have I answered correctly, sir?
I mean, look, I think there are IIT Angels that is coming about with the research park. I think that's Chennai Angels, of course, where Padma and me share a lot of time.
That's all after your
yeah, but I think put your own skin in the game. But I think actually, let me give a slight nuance. There are a lot of guys that chase VC money early because they think AI is a big lead time play. I actually think that's the wrong answer. Let me be blunt, because a VC has a shelf life of 7 years. Please understand this, all venture capital funds have a shelf life. Meaning that that fund has to return the capital to somebody else that's given them that money. And it's normally 7 years, sometimes 9. Healthcare and AI or deep tech in healthcare, my experience has been it's a 10 plus year cycle. So that means, and our friend is here, so he's come for funding. We actually offered to write him a check and then he ran away because he got somebody who wrote him a bigger check, right? But the reality is, I think if you find good angels after you put in significant skin. So put in skin. You've got to believe what the hell you're doing is going to solve a really big problem. And this is 10 years of your life is going to be invested to succeed. You do that and I think you will get enough money. I think the money journey for now, healthcare, serious problem solving, there's a lot more than there was when we were a bit younger. And when he looked as young as his photograph over there. But I think the reality is, I think the fuel is there, but you have to start. And I think that's the problem most people find. How does a student go and find fuel early? You have to put some in, you have to bootstrap, you have to keep costs low in the early days and somehow make it. And I think you can talk about your noodle nights.
Okay, see, the one takeaway from healthcare AI companies is that, you cannot make an exit in less than 10 years for sure. Right? There are companies where you can exit in 3 years. There are businesses which you can exit in 5 years. But with health tech or serious AI companies for healthcare, you don't imagine an exit in less than 10 years. So which means you have to stay afloat for at least 10 years to prove the point. So if you take VC funding early, you're going to let go a big chunk of your company. So going for VC funding at early stage is a suicidal. I would call it a suicide, right? So I'm in my 11th year. So we are going to VC funding only this year.
Wow.
We survived 11 years with revenue and funds from friends and family and some friendly angels and stuff.
Great.
Right?
So yeah, I think, we are almost out of time. Raghu wants to make a quick point and then I'll just open up for a couple of...
Yeah, just remember that there are many problems that need solving and are worth solving. Not every problem lends itself well to becoming a business. And not every business that is worth founding lends itself well to a VC fundable model. Right? So just keep this in mind.
Sure. So now I'll open up. Already I have a hand up. Can we have a mic? Do you have another mic, or shall I go around? Shout it. Or you can shout your question. That's working.
Yeah. Good afternoon. As small startups, there are big mammoths in the industry that create, let's say, competitive patents or multiple things that improve their credibility. But when we work in softwares, let's say, for example, other than an academic backup that we have for the credibility of the startup, what else can we invest into so that the regulatory aspect or the confidence that we create for the investors, or let's say a quality product for that matter, because VCs don't fund if you don't have a patent. So how do we go through that for the softwares?
Can I take it?
Yeah, I think one person can respond in the interest of time.
Sure.
Yeah.
See, I don't think patents are mandatory for VC funding or for any angel investments, right? See, what matters is what is the correctness of your solution, right? Does it ring a bell to your end user? That matters more than what technology you use or who's your competition. Don't worry about that. See, the good thing about having a mammoth competition is you have a potential buyer of your company. So your exit is confirmed for sure. Right, so be happy about it. So don't panic when you have a mammoth competition. Just look at the opportunity. When you go to a reasonable size, they will be the first one to very interested in buying you out for a good money. So look at the brighter side of the story. And when it comes to competition in the space, customers care about what is the cost advantage they get and what is the quality that you can promise. So unfortunately, in the AI space, the industrial AI space, there is no guarantee on quality. Nobody guarantees that. So I think Buddy AI is one company which is crazy enough to give guarantees on quality. So we give 95% accuracy guarantee, or 95% correctness guarantee for the volumes of data processed. And we also guarantee 70% volume. I mean, if you give me 1 million documents, I will at least process 700,000 of them in autonomous mode. No human intervention whatsoever. We were crazy to do that. But we are standing out. I mean, no one is giving guarantee, including 3M Optum. Just imagine any big giants in the space, right? So find out what is the differentiator you can provide to the investors. What is a differentiator you can provide to your customers, right? What is a differentiator you can provide to your fellow team members? What is a differentiator you provide so that they hang on with you, work with you for a longer period of time? So you have to convince three parties. One is you need to convince somebody to put money on your idea, number one. Second is you have to convince somebody to buy your products and pay you money. Third is you have to convince someone to work with you, hang with you for a longer period of time. So you have to have these three skills to run a business. I think.
Summing up, just one small question. We were talking about, protecting ourselves. So let's say we have a hardware that, of course, we can, get some way out through the patents or something like that. We spoke about quality, cost effectiveness and other parts. But how do we then, keep that process of, let's say, we're not talking just about AI. Of course, these are softwares that are very easily replicable. So that's how do we protect ourselves under this matter?
Of course, there are designs that you want to protect. There are algorithms, not algorithms. There are systems that you want to protect. Okay. Patenting is the only way to go about it. Okay. Right? You can go for design patents, you can go for systems patent, okay, but patent it across multiple nations, right? Not just India, patent in Japan, Europe, Americas. I mean, all these areas you have to patent. That's going to cost you a lot.
I think the simple answer to this is stop wasting your time thinking about patenting. By the time you patent it and write it up, the world has moved forward.
Yeah.
I think in this space, it's damn moved forward. So yeah. I think just move fast. I think if you solve fast and you solve a real problem that gets somebody to pay, you will get people to come and love you and long enough. Whether your spouse spends enough, if you don't go home enough for 10 days a week, your interest, your spouse and your kids have lost interest, right? There are reasons to do patenting. But I think if you're moving fast, that and then overthinking of protection.
I was just going to say, second last, think about the customer. A few paying customers, then about, intellectual issues like patents and so on.
One last.
Hi, good afternoon to all. And just point as somebody who's now in the startup space, being a physician, I think one of the huge issues which you discussed right at the start, the one on data, um, with the National EMR Standards Committee, which finally said that it is recommendatory and not mandatory. Can there not be some kind of pressure exerted on the government to make EMRs mandatory in some form? Because we are struggling to get Indian data. We've got a lot of data, but it's basically stuff which hope, fingers crossed, will also be applicable to an Indian patient. You would have the same experience as well. So there is no large volume Indian clinical databases that are complete and comprehensive. And one would think for something, like AI, that would basically be the starting point. So I'm trying to understand from you, what is it, every major developed country has made electronic medical records mandatory. What is it that inhibits the government, and why can't they say 5 years' time, it should be mandatory? Don't you think that that should be a starting point for anything? The point also that she made, last point, about most of the startups in AI in India working in the imaging space is because imaging space at least has quality data available in India, whereas the clinical side does not.
No, quick answer to this is India is going down this path. This is what is happening through the Ayushman Bharat digital mission. But
Not
it's
mandatory,
a process.
sir. It's not, the ABA number is not mandatory.
No.
It is only an optional this thing, and also the linkage of the record itself is also optional.
I'll simply say this. It's not a simple black and white. If I today mandate suddenly overnight that this is whatever, there are going to be lots. You will see a revolt of various types. You will see disenfranchisement of various types in various sections of the community where geographies are underserved, capabilities aren't there, etc. So it's a journey. And I think what's happening is we are going through that journey. Remember, the mature EHR systems that you're talking about have been a result of 2-3 decades of work. It's not overnight, right? Yes, we will do it in an accelerated manner, but my bet is India will still take about 7 years from now, 5 to 7 years from now for EHR systems to really be there. And I think that'll be an achievement because we would have done it in essentially a decade's time.
So I think we are completely out of time, but one last, I think a person has a mic there. So yeah, do you want to quickly?
Yeah. Quick question, like slightly more generic on AI on healthcare. So I think with advent of Google Maps, right, they say we have lost the sense of direction. So with so much AI, are we going to create clinicians who are more dependent on technology, which is not overall desirable? Or slightly to put the question other way.
I think there are a lot of clinicians here. I think you can ask their opinion over lunch, right? I think this will start another thing, right? But a thought, food for thought, right? While we have lunch, we can also chew on this, right?
Many of you have lost the ability to write beautifully because of computers.
Raghu, the way I say it now, somebody like me who has poor handwriting is able to create beautiful documents thanks to computer, right? So I think on that note, we'll have to conclude, right? We are already 40 minutes behind lunch and I can hear a few grumblings from people's stomach, right? So let's first thank a fantastic panel that we have here, right? So they've taken the time to be here with us, and we have a small token of appreciation of the time you've taken. So I request myself to hand over.